So, Gabriela, thank you so much for making the time and making the schedules work because you are in a different time zone, right?
I know. And it's funny because any day of the week I might be somewhere else. Today I'm in Boston. So there you
Oh, so
go.
not so different. Okay.
Hey,
Right.
well, last time we were meant to record last time I was in Sydney, Australia. So.
All over the world. I would love to start by just sort of asking you about the history of your passion for this topic of infertility and couples' intimate relationships. Like, what got you into this, and why have you built your whole career on it?
Yeah, it's interesting, isn't it? Like I remember being in high school thinking, what am I going to do for the rest of my life? And deciding that I didn't really know, but that there were some things that I was interested in. And I started very much with a very kind of broad interest in nutrition that then developed into me going and doing naturopathy as my initial degree. So I studied to be a naturopathic practitioner. And then after that, I did postgraduate education in reproductive health and human genetics and, a master's in public health at Harvard. Now I'm doing a doctorate there. And I can honestly say that how it started and how it's going are very different things, you
Yeah,
know.
yeah, yeah.
Um, but it's really fascinating how sometimes, as Steve Jobs actually said, you can't join the dots until you look backward,
Yeah, yeah, yeah.
and really see what are the things that transition. But I think that the number one thing that happened was about 10 years into my career where I got a couple of patients who had been trying to conceive and get pregnant for decades, actually. One was 10 years, the other was 19 years. And after having had success with those two couples, I realized that I really enjoyed because I was treating people who were preparing preconception preparation, preparing for a pregnancy, maybe struggling for 1 or 2 years up until about 10 years. At that 10-year mark, when I had these two events, let's put it that way, of people who were trying for a very long period of time, and I wasn't really sure if what I was doing was going to help them. And I was still, even after they conceived and had their babies, I was still kind of like, but was it really what I did that made a difference? And then, of course, I decided to transition and start only helping couples who have been infertile for more than 2 years or who
Okay.
have had experienced recurrent miscarriages and really, failed treatments, really challenging journeys to baby. Because what was interesting and what I noticed at that time when I had those experiences was that those women, compared to the women that I was seeing previously, they didn't have the level of anxiety about getting pregnant
Hmm.
that other women kind of exhibited. That for them, it was about getting closure and knowing that they've done everything that they possibly could. It was that whole story of like, okay, when I'm 90, sitting on my porch in my rocking chair, how do I want to tell this story? Have I done all of the things that I could have done? Have I given it my best? And I knew that I could help people do exactly that.
Hmm.
So, and it just felt aligned to me. And so I then started to transition to only treat people who were 2 years or more. And then about 7, 8 years into that, I decided to go and do my master's at Harvard and figure out, but hang on, who are we actually helping? Who are we helping really? And it turned out that the people who came to me, we did a cohort study of 544 patients looking at the demographics of these couples that were coming to me. And the average time of infertility of the couples in that cohort was 4 years. The majority had experienced miscarriage. 51.5% had experienced miscarriages prior to coming to me, and
Mm.
that rate dropped to 13.5% after treatment. And the about almost 50% had experienced previously failed IVF treatment, and the majority conceived naturally. So it was at that point that I went, oh, okay, yeah, this actually does work.
Yeah,
So it
yeah.
took about 17 years in the process to go, oh, this is what I actually do, you
Yeah,
know?
well, and you're still going if there you are getting your
Uh,
doctorate at the
And
right
I
now
am
too.
still going, and I'm still
A
going.
real a real
And
underachiever, aren't you?
you know, again, I never planned this, I never planned that this was going to go this way, but I think that each step led to the next. I mean, I've been doing this work now since 2001.
Yeah.
So, it's certainly, let's put it this way. I certainly don't hate it,
Right.
you know?
Right.
No, truthfully, I do love it.
Yeah.
It really does bring a lot of meaning to my life.
Now, given your long history in this field, I mean, one of the things I'll see in the news is about infertility is actually getting more and more common. Like fertility issues are becoming more prevalent than they used to be. Do you find that to be true? What's going on with that?
Look, I think that there are several things that can be true at the same time, right? I think that one of the biggest changes that I've seen in this field, and certainly whilst doing this work, is the ability to diagnose nuance when it comes to fertility and fertility challenges. And diagnostics have become a whole lot better, let's put it that way. So I think that, while the infertility rates have remained somewhat constant,
Okay.
one of the trends that we're seeing more and more is actually the social aspect of having children being on the decline. So
Mm.
fertility rates are down, which basically means that people are choosing
Choosing not to have children.
not to
Yeah.
have children. And so fertility rates are declining. Infertility rates are pretty steady,
Okay.
right? And so that's, although in saying that, 1 in 6 couples experiences challenges regarding conception, whether that's inability to conceive, inability to keep a healthy pregnancy to term, so it's very prevalent.
Yeah.
But whether that rate has increased or not, it really hasn't. Like if we look at the data, it really hasn't. The one thing that I also think is a lot more is very different these days is that people are much more open. It has become much less taboo to
Yeah.
talk about infertility, miscarriage, failed treatments than it was 20 years ago.
Right. Right.
So there's a lot of that we need to take into account as well.
Right.
So yeah, and disentangling all of that is certainly important because sometimes people think that they're the same thing and they certainly aren't.
Right. Right. So
But
what
one thing
are,
that
oh, go ahead.
So I was just going to say, one thing that I think is really important to note is that there are many exposures in our day to day that do impact fertility and that we may not necessarily be aware of, or people might be thinking like, I'm having this difficulty. Is there anything that I can do? And sometimes things that are actually effective get disregarded because people don't know, they don't understand. It's not really talked about to a large extent. One thing that's really fascinating is that from research, like from actually a finding in scientific evidence to clinical practice of an implementation of that evidence takes 17 years.
Oh my gosh.
So I know, 17 years. Imagine that. So, 20 years ago, we knew that nail polish was an endocrine disruptor and negatively impacted fertility and the rate of conception and keeping a healthy pregnancy to term. Only now that's beginning to be kind of talked about, you know, in kind of media, right? And plastics. And, so there's a lot of different conversations like that has been known for a long time, but hasn't been popularized and
Yeah.
understood by the masses until much more recently. So those are things that we need to take into account too.
Yeah. Yeah. So could you talk about those a little bit, the kinds of lesser known causes or contributors to infertility that people could just instantly change? They're not about a medical condition or a anatomical
Yeah,
issue or something like
absolutely.
that.
Yeah, lots of times people come to me and they say, what are the things that I can do to improve my chances to take home a healthy baby? And I always say, act pregnant now to get pregnant later. You
Okay.
know, I think that that is one of the biggest concepts that if people kind of internalize it, they will automatically guide their choices and behaviors in their day to day. And it applies to both men and women. So let me put that to you a little bit in these terms. If and we have to take into consideration that each prospective parent, whether male or female, is already carrying 50% of that little baby they want to create
Hmm.
within them right now, right? So those cells, those gametes, they are going to be maturing and developing with the environments that they are surrounded and bathed in, so to speak. So, and we also know that maturation takes time. So, for the male sperm, it takes approximately 4 months or 12 weeks or so. For the female egg, it actually happens in two maturation stages from primordial follicle, which is what we're born with and all the eggs we'll ever have, to primary follicle takes about 6 months. And from primary to ovulatory follicle takes another 4 to 6 months. So it's kind of like a 12-month process, for you to get the egg that's ovulated today started being recruited and, kind of promoted through phases
Yeah.
12 months ago. So every single thing that we have in our environment today is going to be affecting our future fertility.
Okay.
3 to 12 months from now and beyond, right? And then on top of that, you have to account for age and entropy that happens just naturally. So when we are looking at optimizing and improving fertility and the chances of taking home a healthy baby, we have to be proactive because the natural state and order of events is that there will be chaos in the system, right? Entropy is a given unless you are working toward optimization. So when people are thinking about, okay, what can I do to improve? It is so critical to be proactive because it's not enough to think that, oh, heroin addicts, they get pregnant, have 10 babies. And so why do I need to do all of this work? Well, the reason that you need to do all of this work is that it hasn't happened for you,
Yeah.
right?
Right.
In the same way. So automatically that puts you in a different category. And a lot of the people that come to me who are in that situation of trying for 2 years or more, they have automatically been removed from the general population statistic of taking 3 months time to pregnancy and that 93.6% of people will conceive within 2 years, right? So if that's the case, or within 12 months and then 96 point something within 2 years. So that being the case, we have to differentiate, okay, how are these people who take longer different from the people who don't take as long?
Hmm.
And so that also takes into account the things that you need to do. But going back to how we need to essentially look at this whole act pregnant now to get pregnant later, it's like this. All of the things that you would absolutely, so if you were pregnant right now, whether you're a man or woman, the men have to indulge me for a little moment,
Right.
but if they were pregnant right now, we all know there's a laundry list, arm long list of, details that we know that we would be able to do or stop doing if we wanted to have the healthiest possible baby. Like all you have to do is ask a woman, if you were pregnant, what are the things that you would start doing or stop doing right now to have the healthiest possible baby? She would enumerate a
Yeah.
whole bunch of things from drinking, smoking, exercising, taking prenatal vitamins, like eating
Yeah.
well, blah, 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 blah. The list is long. We all know it. The same applies to the male counterpart because of that conversation that we've just had, that we are already carrying 50% of that little baby we want to create.
Right.
So the rest of that is just having the meat. But if the cells, to the originating cells, aren't the healthiest possible cells, and if they are maturing in an environment that is high inflammatory, high oxidative stress, toxic in many ways, guess what? Those cells are not going to be the best quality cells, and they're not going to yield the best quality embryo as a
Right.
result of it. And then what ends up happening is that you will hear, oh, it's taken a while for you to get pregnant. Well, just go do IVF. And you will go and do IVF, and you'll either end up with no eggs or no fertilization or embryo quality that's poor, no baby. And you will be told, oh, but it's a numbers game. Just keep trying.
Yeah.
And it's like,
Spend
hang on a second.
spend another 10 or $20,000, right? In the
Well, it would
meantime.
be nice if it was only 10, like in the average number of cycles that a couple needs in order to have close to an 80% live birth rate, according to the science, is eight.
Wow.
And an average cost of an IVF cycle in the United States is between 15 to 30,000 US dollars.
Wow.
So 10,000 would
Crazy.
be a bargain, a
Yeah, right. That'd be
bargain.
the midnight sale or something. All right. So then when we get to what are some of the other causes of infertility that are not as easily controlled as just making those right choices, right, for men and for women?
Yeah. So, look, anything that is health related, so whether we're talking about, and sometimes these things are not necessarily the most overt, right? There are many silent causes. I'll tell you one that's very um, unexplored and often ignored:
Hmm.
blood sugar regulation and insulin resistance. It's a major cause of poor quality cells in both men and women. It lowers testosterone. Like if you're insulin resistant as a man, it's going to lower testosterone in the testes. It's going to block the ability of stimulation from LH, luteinizing hormone, to actually produce sperm by the Leydig cells. So the reality is that often we hear about insulin resistance and irregularity of cycles in females, and men are completely ignored. But the
Yeah.
effect is the same, you see. And so that's why I always say fertility is a team sport. You can't ignore 50% of the equation and hope that you're going to get a better result if things haven't been straightforward. And I think that that's a mindset that a lot of times people they ignore, is the fact that it's a completely different conversation if you are part of that population that has conceived easily, and or you've tried for 12 months, haven't conceived, went to IVF, got pregnant first try. Those are different people.
Right. Right.
Okay? When there are these underlying blockages that we sometimes don't immediately pinpoint, or it gets ignored because it's like it's borderline, like you have a result that's like, oh, you have great sperm count, but morphology is a little bit low, but that's okay because your overall count is so good, we don't have to worry about it. But then you've had 10 failed IVF cycles. Let me tell you, that has a part to play, you
Right.
see. And so a lot of the times it's the obvious, ignored and unaddressed, that continues creating these negative results. And what's important here is to understand from a reproductive modeling perspective in terms of live birth rates and effectiveness in terms of results. This is what it looks like. And these reproductive models in terms of results have been done across populations. And they pretty much hold across multiple different geographical locations. And so what happens is this: if you have a couple at peak fertility, you have an expectation that you have 3 months time to pregnancy. So literally it's have sex, get pregnant, have a baby, done. We're no longer having this conversation. When we're still having this conversation, if you add a minor factor, let's say insulin resistance, irregular cycles, morphology issue, slightly low count, whatever, pick one, right? All of a sudden, we go from an average of 3 months time to pregnancy to an average of 2 years,
Mm.
just from one minor factor,
Yeah.
right?
Yeah.
You add a second minor factor, PCOS, endometriosis, like you name it. Again, just whatever you want to add into the equation. All of a sudden, we go from an average of 2 to 7 years.
Wow.
A third minor factor gets us to an average of 40 years time for pregnancy. Nobody has 40 years to get pregnant. You
Right.
see?
So
And so no matter how early you start,
when you're saying minor factor, so it sounds like most I don't know if I'm concluding this right. Most infertility issues are from not taking these minor factors more seriously, just thinking, that these are
of the
not.
patients that I see, 100%, a
Wow.
100%. Because you see, what happens is the body can, homeostasis is a very important process in the body that helps us to kind of, mitigate issues that arise. And to a certain extent, we can do that. But over time, our ability to mitigate these states of imbalance starts to become depleted. When it comes to fertility, the older somebody gets, the more difficult it is, unless, again, we are working on syntropy, we are going to end up with entropy. And so what happens is that modulating all of that with time becomes more difficult. So if you are experiencing infertility in your 20s, you absolutely know you have a problem because
Yeah.
that is your peak fertility years. Now, when women start to get to 30, 35, 40, 40, over 40, they start to hear like, oh, this is because, you're getting older and it's an egg quality issue. And it's never just one thing.
Mm.
It's never just one thing. It's always going to be a combination of these factors. And because they're not take I can't say that, okay, this is how I'm going to phrase this. In the general universal healthcare systems around the world. So there's different kinds of healthcare systems. In the US, it's more privatized. In Canada, UK, Australia, it's universal. And so that means that it's heavily subsidized by the government and, basically taxes and so on. In both of those different types of healthcare systems, there are misaligned interests. And so what happens is that there is either a situation where we want to limit the amount of access that we give to couples trying to get pregnant to testing and treatment because resources are limited.
Hmm.
So universal healthcare systems, that happens. Like you might get 2 cycles of IVF, but you have to meet certain criteria. And if that criteria is met, then you are no longer eligible. But what happens with that is that the healthcare system says, if you're going to treat anyway, why test? So uncovering the issues that may be leading to the need for
Yeah.
IVF is not done
Okay.
and not looked at because the idea is, oh, IVF will bypass this anyway. But you see, we know that more than 70% of IVF cycles started fail, do
Yeah.
not yield a baby.
Yeah.
So the effectiveness isn't, like a lot of times people think they're going to do IVF and that's how they're going to end up with a baby. Sadly, it's not what happens. In fact, it's the majority, the opposite result.
Right.
You go through, you will start and you will not end up with a baby. Now, in privatized systems, privatized healthcare systems like the US, the idea is let's maximize the number of cycles because that's how we increase profits. And a lot of privatized clinics, they have shareholders.
Hmm.
So who do they owe
Right.
at the end of the day? You
Yeah.
know, a kind of response. It's to shareholders.
Right.
So patients don't get that nuanced diagnostic answers about why is this not working and what can I do about it to prevent the need for treatment or to treat in a different way because it's just not part of standard therapy.
Right.
So it's a huge issue for a lot of people who struggle. The
Right.
people who it happens easily for, and again, mind you, it's the majority of the population. Therefore, as in public health, as you can imagine, if you have limited resources and you don't need to allocate, you need to, whatever funds you have to allocate to do the very least for the most number of people. Infertile couples are not going to make that cut
Right.
because people are dying from cardiovascular disease, diabetes, cancers at much higher levels, and the resources go there.
Yeah. Although addressing some of those things would improve people's fertility, right? If they
It
address
would
their
improve
overall
people's
health,
quality of
it might,
life. It
yeah.
would decrease their need for treatment, for
Right.
cancer, diabetes, cardiovascular disease, like
All
you
of it.
name it.
Right.
But you see, this is the other flaw of the healthcare system. If it's going to cost the same amount of money to prevent a condition as it is that to treat the condition, the healthcare system will not prevent, it will treat.
Wow.
It's very sad. It's
It
it's
is.
devastating to me. That's why I went to do public health at Harvard because I'm like, okay, we have to change this.
Yeah. Yeah. So you were talking about some of the minor causes that are sort of physically based. What about chronic stress and things like that that are, I don't know if you call that emotional. I mean, that's also physical, but what's the role of chronic stress in making this more
Look,
difficult?
chronic stress is definitely going to play a role, but it's about the chicken and the egg, right? It's like what came first? Is it that
Yeah.
people are infertile and having challenges that is making them stressed, or is it that they're stressed and they're having challenges? It's a combination and it will be differential for different people. And the reason that this is important to note is that, people in war zones get pregnant all the time
Mm.
and have babies,
Yeah.
right? So we cannot say that stress causes infertility, because
Right.
if that was the case, that would mean that nobody in war zones would ever get pregnant,
Right.
right?
Right.
So it's, and of course, there are situations of trauma-induced infertility and infertility-induced trauma. You see?
Yes. Yes.
So there are two sides to this equation. So what do I say to my patients? You do not want to stress about being stressed. That's the first thing. Okay. Because that doesn't, like, it just
Right.
decreases your quality of life in the day to day. Like, if you're stressed, be stressed and then go and do something that's going to help to liberate that stress. Go running, go exercising, go painting, go, like, whatever it is that's going to help you manage and care for yourself and manage those emotions in the best possible way. And just do the best that you can all day, all day, every day. Now, if you have an incredibly stressful job, guess what? You will need that job to pay for fertility treatment. So
Yes.
you're going to have to somehow manage that stress in a way that it doesn't cause you to feel more stressed about being at work, because that's not going to be helpful. So asking yourself, one of the things that I'm a big fan of is actually writing about what's bothering you
Mm.
and letting it be, letting it go on paper, and getting the distinctions and the clarity that you need to figure out, okay, what do I really need? What is it that's going to help me transition through this path that I'm journeying. So it's one of those things that we want as humans. It's so easy for us to want simple solutions to really complex problems. It's so easy for us to want to find the culprit. It's never that easy.
Right.
There's going to be, underlying infections, inflammation, oxidative stress, mental emotional stress, you name it. There's going to be a whole lot of things. And those things are going to be different for each person, because the way you can line up 10 men with poor motility, for example, right? Sperm like not swimming as well as it could. You can line up 10 men and you can have 10 different reasons as
Right.
to why that's happening.
Yeah.
So, you can have a farmer that's sitting on a motor in a tractor all day long. You can have an office worker that basically is drinking alcohol in their lunch times because they have, that's the kind of job that they have, and they're doing a lot of that. There's lots of
Yeah.
different types of exposures that we have. And that's why that going back to act pregnant now to get pregnant later helps people to think about, okay, in my situation, if I was pregnant, what are the modifiable behaviors that I need to implement that is going to make a difference? Now, from a clinical perspective, I know that I need to test for a whole bunch of things, whether it's infections, inflammation sources, like you name it. There's a whole lot of things that we need to rule out. But at the same time, those two things go hand in hand. It's like the clinician needs to do the things that the clinician needs to do, and the patient needs to do the things that the patients need to do. And those things, unfortunately, aren't interchangeable. I
Right.
can't give somebody a supplement to eradicate all of the bad behaviors that they, might go in and do, in the
Right.
same way that we can't just have a fabulous lifestyle and not treat chlamydia and expect a healthy baby.
Yeah.
So there's so many of those things that need to happen at the same time. It's like all of the things that need to be true for this to be true.
Yeah.
There's a lot when it comes to fertility.
Right. Right. All right. So could you speak to sort of the path of somebody working with you? Like what is the basic process they go through in your
The first
clinic?
thing I do, yeah, the first thing that I do is assess the case. So we only take on couples who have experienced either challenges or failed treatments, or know that there is a potential for failed treatments. And so we don't work with people who have been trying for 5 minutes and nothing has worked,
Right. Right. Right.
We treat difficult, complex cases. So first I assess the case to figure out, okay, is there work to be done? Is there work we can do? Have we done it before in a similar set of circumstances? Are there any deal breakers? Because sometimes I get people who come to me and they will say things like, I have 2 blocked fallopian tubes and I will never do IVF. And I'm like, okay, I am good, but I'm not that good.
Right. You're not
I'm not
magic.
a magician. I'm not a magician. And so an immaculate conception is not part of my training. you
Right.
know?
Right.
And so there are things that no matter how much cannot be done without technology. But it's about assessing and understanding those pieces and disentangling them from everything else that can be done. And then the fifth thing is really looking at, how does this person compare with patients who have gone through my program, and we use data now. We use a predictive model to be able to assess that,
Right.
because I want to demonstrate clinical effectiveness. Because in order for this to be something that's useful on a general population level, first and foremost, we have to demonstrate clinical effectiveness, right? And for that to be the case, I need to really only work with the people that I can help. And if I can't, then I would much rather refer them elsewhere that can help them with what it is that they need than to take them on and decrease my success rate. So, there's a very important piece here that, it has to work for us for it to work for somebody else.
Right. Right.
And I'm very transparent about that, because a lot of times people think like, oh, this person, they just want to make money. It's like, no, 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 no.
Yeah.
Like,
You want to make
I'm
a
actually,
difference.
I want to make a difference. I
Yeah.
want, in the next 50 years for patients not to have to go through this
Right.
conversation. And so that really is the whole situation. And so that's the first step. We do a complementary fertility assessment, assess if we can help, and then of course if we can talk about next steps. That's essentially how I usually work.
Okay. And then what's the basic path of next steps? Is it all that testing like you're talking about and get clear
Yeah,
on what
so
the
we
what the soup is for each couple?
exactly, yeah. Hey, I love that. I love that terminology. Yes, it's really about figuring out what are we dealing with first and foremost, right? So my fertile method, the first step is fact find, and then we're educating, and then we're recommending, and then we're treating, and then we're looking at incubation because it takes a certain period of time, right? And in that, we're looking at the liberation process, because also it's about like how do we disentangle from this like I have to have this result or else, so that we can end up with the result that we're looking for, and or have closure on what needs to happen. Like there are people who they are only willing to do things to a certain point, and that certain point may or may not lead them to the result that they want,
Right.
and or may lead them to something else that they might decide to try that they weren't open to beforehand. So the method really does take people through this entire journey. And at that point, they're able to say, okay, yeah, either I have my baby or I've done everything that I possibly could and wanted to. And I'm free to start a new book in my life if that's the case.
Right. Right. Okay. And your work is fully virtual, right? Your clinic?
It is. Yeah, we treat couples in every continent other than Antarctica. And that was thanks to my first son, because I went from like seeing 60 patient hours a week and, being in front of people and then going, okay, I can't do that anymore. So we're going to have to do this differently. And in 2013, I decided to go fully telehealth. So it was a big learning curve at the time where, like video conferencing wasn't really all that great. But we made it work. We made it work
Yeah.
so well that when the pandemic came, we were like, oh, just another day in the office.
And if somebody needs, medication, a prescription, some sort of surgical intervention or medical treatment, do you coordinate with physicians where they
We
are? How does that?
Absolutely.
Okay.
Yeah, absolutely. So we coordinate with the practitioners, clinicians, wherever they are in the world. We usually have a directory that we also can refer to, and that there are clinicians around the world that we have good relationships with, and sometimes we just build new relationships depending on where someone is.
Right.
But the majority of our patients are in the US, UK, Australia, Canada as well. And so basically, but we have patients like in Brazil and Mexico and you name it. So there's
Right.
patients everywhere. But it's really just, one, it's an expertise process of figuring out, okay, what are we dealing with from a biochemistry perspective? And then, of course, figuring out what do we need to do about it and interpreting results in a way that actually has practical implications for improvement
Yes.
of what
Yeah.
it is that we're looking for, because reference ranges mean nothing. Like reference ranges from a lab, which is looking at pathology, compared to what you need for optimal fertility,
Yeah.
are night and day different. I'll give you an example of thyroid function, for example. You might have a TSH result, thyroid stimulating hormone result, that the reference range from a lab is anywhere between 1 and 5 international units per liter. And then, of course, for fertility, we know that anything above 2.5 is going to increase the risk of implantation failure and miscarriage. So
Mm,
if you've got somebody who's consistently higher than that number, obviously we're going to be looking at, okay, and they've experienced miscarriages, they've experienced repeated treatment failure. Of course, we need to address that. But
yeah,
in the general kind of, seeing a standard therapy practitioner, and they will literally be told, oh, yeah, yeah, everything is normal. Just keep trying. It's a
right,
numbers.
right,
Better
right.
luck next time, and
Yeah.
it's like, oh my God.
All right.
So
So
yeah.
tell people where they find you. How do they get in touch? How do they schedule one of
Yeah.
those
Yeah,
consultory calls?
absolutely. Yeah, absolutely. So they can go to my website, which is fertilitybreakthrough.com. That is fertilitybreakthrough.com. They can Google me, Gabriela Rosa, Gabriela with one L, Rosa. And my book, Fertility Breakthrough, Overcoming Infertility and Recurrent Miscarriage When Other Treatments Have Failed, is free on Spotify and on YouTube. So people can listen to that as well and get some new ideas and some new insights from that. And we also run a free educational program called the Fertility Challenge that I have been running now for the last, gosh, I don't know, 15 years, that helps to educate on what are the modifiable factors, what are the things that people can do, and also understand more about next steps that they can take. So those are all resources that are available for people out there who might be wanting to improve their chances of taking home a healthy baby.
Well, thank you so much.
A pleasure. Thank you for having me.